Terry, I don't know if you want to quickly introduce yourself.
Sure. Hi, I'm Sherry Cohen. I'm president of Hepatitis B Foundation, and very happy to be here.
Great. So just a little brief intro into the NOhep Visionaries program. So we launched this program in 2017, and really all around looking at medical professionals as advocates for elimination. You know, medical professionals are so critical if we're to reach elimination. And we wanted to pull together this program that maybe looked at the different roles that medical professionals play beyond just diagnosing and treating people living with viral hepatitis. And so really pleased to be able to bring this forum together today, and Victoria is going to run through a little bit of the objectives of today's meeting, and then we'll introduce the speakers and jump straight into it.
Absolutely. Thank you, Jess. So as you know, there are still quite a lot of challenges in getting people around the world tested and into care and treatment. And we know stigma, we know discrimination, there are systemic challenges, and one of the things that we're trying to do is get rid of some of those barriers and get people into care, and a lot of that is about, messaging. How can we make it easier for people to get into care and access care? And we have been thinking a lot about the U=U message that has worked really well and has had quite an impact on the world of HIV and the HIV community. And we don't know what's going to happen today. We're certainly not going to come to conclusions, but we wanted to start the discussion to talk about what impact or what we might be able to say in terms of undetectable equals untransmissible. We know that one of the goals of treatment is to have DNA undetectable. What does that mean for people outside of reducing your risk for liver cancer in terms of transmissibility to others? One of the things we know, because we've done quite a lot of research, is that the fear of transmitting the virus to others is something that weighs heavily on people that live with hepatitis B, and it promotes stigma, it promotes isolation, both projected isolation and self-isolation. So is there a way that we can kind of message treatment as prevention or something like U=U? And so that's why we're here today. So each of our speakers has a different perspective, and we're going to give each speaker kind of a few minutes to talk about their view and their perspective. And then we have some very specific questions that we're going to pose to our panelists and have some open discussion. We do have the room until 9 o'clock. We know that people may not be able to stay until 9, but we're hoping to keep the discussion going as long as we can. And should we go around the room and do?
Yeah. Do you want to? We just get the speakers to very quickly introduce themselves before we jump in. So maybe we'll start Sue and move along the line.
Great. My name is Sue Wong, and I'm an internist, and I'm the most recent past president of the World Hepatitis Alliance, and I run a viral hepatitis program based at a hospital, Cooperman-Barnabas Medical Center in New Jersey. So very glad to be here.
Cami Graham, I'm an ID doc at Beth Israel Deaconess Medical Center, co-director of the Viral Hepatitis Clinic, and medical director at a syringe exchange program.
Mark Solkowski, I'm up at Johns Hopkins in Baltimore, just a mere 45 miles and 2-hour drive away. But I'm director of our hepatitis clinical program at Hopkins.
Hi, my name is Mike Alibadaro. I'm a director at Prevention Access Campaign.
My name is Patrick Kennedy. I'm from London. I'm a professor of hepatology there, and I run a big viral hepatitis program and clinical research program.
I'm Louis Roberts. I'm a hepatologist at the Mayo Clinic in Rochester, Minnesota, but originally from Ghana, and so spend a fair bit of my time in West Africa trying to understand better the dimensions of viral hepatitis there and help with efforts to prevent and treat it.
Great, thank you. So I think, conscious of time, let's kick off with Cami.
All right, taking my mask off. Okay, we literally are given 5 minutes to talk, and so I'm going to set my timer so I don't go over. All right, so in 5 minutes, I want to talk about the evolution within the HIV care world from treatment as prevention to U=U from a clinician perspective. So in the 2000s, we had this idea of treatment as prevention. There were observational studies that suggested that lower viral loads meant less transmission. We had obviously mother-to-child transmission data. But it wasn't until let's see, HIV Prevention Trial Network, PTN 025 data came out in 2011 that we now had a randomized clinical trial that demonstrated that if you were undetectable, you were not transmittable. Now the problem with this study was it used older regimens, and it came out in 2011, but some of these people were on AZT, and it was about 97% male-female couples, only about 3% men who have sex with other men, and so we really didn't have data on that population. And there was some transmission. Now, there were careful analyses that showed that some of these people that got infected were probably infected like just as the partner was starting treatment, and there were other people that were not undetectable, but it led to a little bit of a mixed message about how confident we could be, in those data. And the other thing that happened in 2011 was we had PrEP that came out, and so we were like, well, when do we use PrEP, and what's this treatment as prevention? And though I remember those times being a little bit confusing. Okay, so then we had the partner study, partner 1 and then partner 2. Partner 1 included male-female couples and male-male couples, and then partner 2 extended the data for men who have sex with other men. And what these were able to show in these observational studies was that nobody transmitted when they were undetectable. It was 0. And this was tens of thousands of sex acts had been carefully documented. And the problem was the confidence intervals included 0, 0.3 or 0.2. And if you think mathematically about what it would take to create data, because it's like an asymptote at this point, to have a 0, 0, it's almost impossible. But there were doctors, again, that were like, well, the confidence interval includes something that's not quite 0, so, it's not impossible. And so there was this like, yeah, treatment is prevention, but sort of stuff. And for me, the transformation occurred when I was speaking at an annual HIV conference in Texas, and there was an advocate that stood up in the plenary session and said, doctors, you need to stop it. When you do that hand-wringing, wishy-washy, a message that's a little bit ambiguous, a little bit caveat, it destroys the purpose of the message U equals U. So treatment as prevention doesn't have the same power. It helps, and it's used in counseling, but I think the reason the advocates came up with U equals U, and that was, it was not doctors that came up with it, it was advocates that came up with it. We were like, we need a clear message. And then they called us, we need you to believe and to say that clear message, U equals U. And if you look at 2018, this was in 2018, you started to see a transformation where more and more clinicians, doctors, other healthcare professionals were beginning to say U equals U. And then if you look at the CDC website on HIV prevention, it might be a year later or so, they started actually saying, if you are undetectable, it is impossible to transmit HIV. We call this either treatment as prevention or otherwise known as U equals U. And I think that government saying, this is what this is, and then having clinicians, support it, allowed us to transform into a much more solid, definitive message about this. And I know that is what gave the power of this message when I'm interacting with my patients. And I'm going to stop there.
Great.
You have another 22 seconds.
I have 12 seconds on my stopwatch.
Great, thank you, Kevin. Now it'd be great to get Michael's perspective from the community point of view on the U equals U movement for HIV.
Thank you. I feel like I don't have to say much anymore. She just described all that happened. I think, but no, from a community perspective, I think it was like, as someone who is living with HIV and who worked in this field for such a long time, and sort of, and always being told that you are infectious, and no matter how much treatment you are on, there's still that thing in your mind that you're always infectious, and your partner, and your friends, and relationship-wise, and having family, and that you have to be careful, you have to disclose, and sometimes even criminalized. I think the conversation about how powerful because you could be, after the studies show that we actually cannot transmit HIV if you're undetectable. And that means getting on treatment is critical. It's a critical part of getting to the first use. So prevention access campaign, when my boss, Bruce Richmond, who sort of worked in the private sector, and he was someone who was living with HIV and had like issues with stigma, discrimination, internal stigma as well. And his doctor told him about U equals U. And he was personally sort of, how to describe it, sort of shocked that this message was not being told the way it should be. And when you go to your doctors, they don't tell you that actually if you stay on treatment, you can achieve viral suppression, and you can actually have family, you can actually have raise kids without transmitting the infection to your family or to your kids. That is such a powerful message. Can you imagine in African countries, and even here in the US, people are being criminalized because they live with HIV and because they don't disclose their partners. Those folks are actually undetectable. So the fact that actually just saying it can change laws, can actually change perception, and can actually make people not go to prison, that is so powerful. So the power that medical field had was stunning, that they could not even say the word that if you're actually detectable, you cannot transmit HIV. And I think one of the breakthrough we had was when we were able to convince Dr. Fauci to say it. And when he said it, it transformed the field entirely, because Fauci said at the AIDS conference in Amsterdam that if you're undetectable, you cannot transmit HIV. And it's zero chance. Not maybe, we are not really sure, not 1%, because even CDC and USAID and US government, they were saying, well, it's effectively not possible. We have to tell them, can you remove the word effectively? Because that means you are giving people a chance to doubt as well. Like, what does it mean by effectively not possible to transmit HIV? So I think messaging was key for us. So at PAC, we took the word U equals U out and make community feel that they owned it, that they can go to their government and they can go to their medical field, their doctors, to tell them, actually, I know about U equals U. Can you tell me more about it, my doctor? Like, we invested in community education and campaign. So we started, my boss is, it came from the communication ad world. So he took that message and make it a global, relatable message that if you're undetectable, you want to. As someone living with HIV, for me, I think I had a conversation with my parents at the very early stages, and when I told them about U equals U, they were initially shocked, right? Because they thought that you're going to die, you can have kids, you're good, there's no way this treatment you're taking to save you, like we said, because we have this word in Africa, meaning you can cure. There's a native language for it. So we had to transform that language in Nigeria to say, actually, yes, you can cure it, but actually you can live a very well lifestyle, even if you're HIV positive. And that you have an incentive to stay on treatment, which is key. So for us, the message was not just that prevention as treatment. It was a very well lifestyle, that you can have kids, that women in Africa can actually have kids, that they can tell their husband that, yes, I'm positive, but actually if I stay on my treatment, if you stay on your treatment, we can have a family. That is such a key message to tell people. Like, it's not just like to make people feel better, it's actually to transform their life entirely. So for us, it was like, we own the power. We have to work with the government. So we have partners in over 100 countries and work around the world. The goal was initially to make policymakers change their policies, to put in the document, in their HIV guidelines, that actually, if you're detectable, you cannot transmit HIV. And for us, right now at PAC, what we've done, apart from just change the messaging, is to make sure like this message can actually change the epidemic, can actually end HIV. Because if people have an incentive to get on treatment, that means they cannot transmit HIV. And that means the rate of new infections are going to drop dramatically, obviously in addition to PrEP. So for us, it's like, yes, it's a personal gain for us as PLHIV. Yes, it makes us feel better, but actually it's not just for us, it's actually for the field as well. So investing in treatment, investing in PLHIV can actually end HIV. So that is like the key message. Obviously the field is still a long way to go, but I think we've come such a long way. And I think the message for me is like, it's transformative. It's like, I don't know how to describe it. When I tell people, there are folks around the world who still don't know about the message, who are still in denial, doctors who are still in denial that when you're HIV positive, when you're on your treatment, you cannot transmit it. So I'm going to stop there. I feel like I can take some questions later.
Great, thank you. And I believe, do you still need to leave at 8 today?
I can wait 5 minutes or so, yeah.
Well,
So-
maybe we'll just open it up
Yeah.
to a couple of
I
questions.
would think that might be a good idea if you have to leave. So I actually do have a question, and you just kind of hit on it at the
Yes.
end. Are there non-believers? Are there people that still push back? And how has that impacted the message?
Yeah, I mean, there are folks in the HIV world who still push back, advocates in government, who still tell us that, well, you know, first of all, it was about this message is for white cis men, for gay men, and you know, it's because it's sexually untransmittable.
Right.
So for breastfeeding women, what do you know about that? Can you tell us more? And there we got pushbacks from women who felt like, well, yes, we know we cannot transmit via sexual transmission. Yes, we can have kids, but actually, what about breastfeeding? So we are actually also going to working to do more studies to show that even though we know practically it's not possible, but obviously we don't have a research study to show that yet. So that's why we're still investing in research to show that actually breastfeeding women can actually not transmit HIV. That's one. But also people in the field as well. Yeah, people who just feel like, well, it became a war between the prevention world versus the treatment. And it became a war between PrEP and treatment prevention. Even though we are all in the same field and we are always categorized as a stigma reduction message.
Yeah.
Yes, the stigma reduction message, but actually it's more than stigma reduction, right? It's actually a prevention option.
Yeah. Wow, okay, thank you.
Yeah.
Any other questions? And if you have a question, can you just identify who you are first and then.
Okay.
I have a question for one.
Sure.
I have a question. Hi, Michael.
Hi.
So I think there's kind of the two sides of this, right? There's the scientific side, and then there's how you describe so eloquently the human impact side. So I think if you're starting, maybe if you could think about, obviously the science of hepatitis B is different, but what would you think would be the steps that we should be thinking about taking in those first steps about exploring U equals U message for hepatitis B?
I think for me, for U equals U message for HIV, what we did was first of all convince and show. So science does not lie, right? You just have to state the facts. And I think with the study we did for the HIV field was to show that yes, actually you cannot transmit HIV if you're virally suppressed. So if you have the same facts, I think that's the strongest evidence or power you can use to convince the scientific world. Yes, people would doubt it, but actually, if you actually someone who comes from the scientific field, you shouldn't be doubting the data that shows that you cannot transmit HIV. So transmit HB. So I think that's the most powerful tool you could have. Sort of convincing the medical world first, it's the key word. We had to write journal in the sort of scientific journal and had Fauci speak about it to convince that scientific world first. And then we go to the community secondly. So I think the same way, I will think the same way, yeah.
And
That's why we're here.
I have one last question. Did you have difficulties convincing Fauci and some of those senior sort of policymakers, those sort of to get on board with the messaging?
Yeah, of course we did. You know, it wasn't as easy. But even Fauci doubted the data that came out first in 2016, 2017. And he actually supported the partner study that came out after because he wanted to make sure before he said anything about it that it was actually factual. And we had convening with him, you know, we had met at the White House at the time to sort of not convince him, because he's someone who believes in data and science and sort of facts. So when he saw the facts, it's like, yes, actually, there's no way to say effectively impossible or maybe it's one chance. This data shows that it's actually impossible. And when he said it, it sort of transformed the field.
Great, thank you. Well, if there's no other questions, this actually leads very, Homie?
I do have a question, because public health is a logic field. It's based on logic, whereas medicine is evidence, right? So we need evidence. The question is, since we've already shown U equals U in HIV, logically, do we need evidence for B? Do we need to do multiple year trials? Because once the viral load is below detection, isn't it safe to assume there will be no transmission?
I assume that too.
I think Mark's actually going to cover this.
Yeah, no, I think it's a really, actually,
Yeah.
Good segue.
I'm thinking about guidelines, and it's interesting as you're talking.
Yeah. And I think, I think the most powerful people to push the message are people living with HB too. I think like them saying it and getting behind it, we have to put the scientific word, but also as PLHIV folks ourselves, we wonder how powerful that message is for our families and for our friends. And we were the most powerful tool to get it out.
Yeah.
So I think that it has to be the same way. You have to convince people who are living with the virus first, and to get them to believe that this is actually true, and they are the most powerful tool you have to put the message.
Great. Thank you. Any other questions? Yeah.
I'm just interested to know how the message, whether it means the same thing in different cultures, and perhaps in some countries and cultures, people are already more oriented towards being able to talk about their HIV status, which is kind of the first, there's a chicken and egg about whether you talk about your status and whether you talk about your undetectability. And does that vary culturally, because different cultures have different willingness to talk?
Absolutely. And the way it helped in that sense is it gets people to want to get tested. Right. I think there are different languages and different terms, but I think when someone talks about in their own, because for instance in Vietnam, they had the K plus K campaign because they use their own words and their own culture. They are one of the best model in the world about U equals U. And what they've done is they get their community to first of all like, hey, they have the broad message first, like, here, when you have HIV and you're on treatment, you cannot transmit it. That gets people to say, okay, so I don't have to be stigmatized if I go get tested. So even if I get positive, I can get on treatment, I can achieve U equals U. That's a key message to even get people to get tested and so to get treated. People use the campaign in different ways. What we do, we provide like the broad message of folks. And people transmit in their own way, in their own culture, their own language, and we supported them to do that. I think like in Malawi, the same way, they have like different sort of campaign, but it's a different language, but it's effectively the same campaign. And people are using it in different cultures. We have like, in Nairobi, it's like wives. They have like those wives community who come together to talk about U equals U for wives living with HIV and to how to get their husband to buy into the message. So like different cultures, different community are like using, the broad concept is there, but they take it and transform it in their own way. And we are very happy to support people to do that. I think that's key. You cannot just have like one broad sort of, message and have people not be able to transform in their own language in their own ways.
Great, thank you. Any final questions for Michael before he has to leave?
I have to walk my dogs. So
Okay, great. I think some of that conversation leads really nicely into what Mark's going to be speaking about in terms of what data we do have for hepatitis B.
Well, great, thank you. Yeah, I must say I hadn't intended to talk about guidelines, but as I listened to the conversation we've had thus far this morning, I wanted to think a little bit about guidelines. I had an opportunity to serve for about a decade on the Department of Health and Human Services HIV guidelines, writing sections on Hep B and HIV co-infection, but also participating in the larger group and thinking about some of the decisions that informed this committee. A couple things. There's no vaccine to prevent HIV. That's an established fact. I'll talk about how that affects Hep B. The guideline panel does not use what's known as GRADE. They don't apply this rigorous evidence base. That's not to say they're not evidence-based, but they don't hold themselves to a standard that's unattainable in some cases, and that's important. And an example of that is the US, this guideline panel adopted treat everyone with HIV several years in advance of the rest of the world, who, because many other countries, investigators, worried about cost, et cetera, they wanted to do a large trial. They did that large trial and proved the prospective cohort known as NA Accord was correct. We were 3 years ahead because that guideline panel wasn't held to a rigorous standard of evidence. And then the second thing, they added very quickly treatment as prevention as yet another reason. Now, the debate there is the guidelines are for the management of a person with HIV, yet treatment as prevention is talking about other people. Now, one might argue the guideline is now extending outside of what it was pulled together to do, but yet this panel is focused not just on the treatment of that person, but the bigger picture as well, and out of that evidence. Which takes me to hepatitis B. So, European guidelines, well, Patrick's not in the EU, but I'll let him talk about 2017 guidelines. AASLD 2018, many of the societies are applying grade, evidence-based. And how does that impact things? And then what I would say about the guidelines, the other thing about the HIV guidelines is they empower the community. They're actually written to say there is a healthcare provider in a room with a patient, a person. How can these guidelines help provide better care? That's the mindset that actually Mike Sagg, who was leading the guidelines when I joined, actually would say. He did the same thing when we started the Hep C guidelines. Hep B guidelines are not written that way. And in many ways, in my own clinical practice, I don't really feel empowered to treat a person with a high viral load and a normal ALT because I am now going against guidelines. And now, do I feel like that's wrong? No, but I am going against guidelines. And that's an important point. So where do we have evidence? A couple of places. Mother-child transmission, very important. WHO adopting the guidelines for delivery into tenofovir-based therapy between week 28 and 32 of pregnancy. Now, I'll also ask, though, the question, is that U equals U? Well, no, because they don't say treat, get the pregnant person's viral load undetectable before delivery. They say treat at 28 weeks because tenofovir is so risky, or I don't know why they say that, but many women may start with a high viral load and you won't reach undetectability by delivery. Now, yet in the HIV world, we give tenofovir from day 0 of pregnancy all the way through with a tremendous evidence base that that's safe. But we didn't really adopt U equals U in maternal to child transmission. Interesting concept when you think about it, because it's the logical next step. The other place is healthcare workers, where when you look at guidance from different organizations, there is the sense that there are recommendations in black and white text that someone who is on antiviral therapy with a suppressed HBV DNA can perform high-risk procedures. They've really singled out what are described as high-risk procedures. Think cardiothoracic surgery, someone's doing a coronary bypass graft. But how does that play out? Is that well known? Is that well discussed? Do hospitals not worry and have their risk managers and lawyers start to talk about that? I was once part of a discussion about, well, how do we know that this person is going to take their medication? How do we monitor that? How do we know? What's our risks? So there's not this basis for that. And then when you look at what that does to the individual who may want to practice, I'll use just one example where this was a young physician who wanted to go into cardiothoracic surgery. Actually did with a high viral load, and we had a lot of discussion. It lasted almost a year about treatment. Now, why did that conversation take a year? Because the guidelines said not to treat him.
Wow.
And I was proposing something that was not part of the guidelines. So that lack of discussion of the guidelines didn't really give me or my patient the power to think about transmission. Now, we ultimately did start antiviral therapy, but think about, I tell you, I'm actually still refilling his antiviral prescription, even though that was about 4 years ago, and he's been in multiple training programs, in part because of the concern that as he enters a new program, to find a new healthcare provider, to have that conversation. What if peers find out? Now, if we had an accepted by patients, by guidelines, that U equals U for Hep B, I'm not saying it would be easy, because it wouldn't be, but it'd be easier. So my last point is, are we going to get the evidence? Well, I pulled up the 2012 Hep B NIH consensus published in Annals of Internal Medicine. And it said there's no evidence treatment does anything for Hep B. Well, it does say that. And what they said was, we need large randomized controlled trials to prove Hep B treatment helps people. Now people say, oh, it'll take 10 years, we won't get the trials done. Well, that was 2012. What if we had started a big trial? So I think we do need more evidence, but we also need to interpret the evidence in the context of the current situation and in the prospect that those large trials will take years to complete and people can be helped in the interim. I think Patrick may talk, the guidelines really stood in the way of discussing treatment. I could think of another, in this case, a young woman who came in with her partner, and we talked about that and this issue of trying to ensure that he was vaccinated and protected. And anyway, but again, not empowered in my clinic by the guidelines to use my best judgment as to what might be right for her at this point in this situation. So I think guidelines have a really important role. And although I come from the academic side and evidence-based medicine is incredibly important, I think you could think of many examples where that's kind of steered us wrong, or in the case of the HIV early treatment, what the eventual trial that was done proved is that strategy saved lives and also prevented transmission. So I think that we do need to start to think about the evidence we have, assemble that evidence in a formal way, and discuss the potential benefits in a guidance document about different sciarios where U equals U is important. I had a few more I wrote down, but I feel like I'm at or beyond my 5 minutes, so I'm going to stop.
We can hopefully we'll have plenty of time for discussion at the end, so I'm sure we can pick up a lot of those points. But yeah, we'll move on to Patrick now, who I believe is also going to touch a little bit on guidelines.
Yeah, thank you very much. Yeah, just listening to Mark makes me think about, I don't quite consider myself a fire starter, but I do want to challenge the status quo. And when we look at the guidelines, and very broadly, if you consider those phases of the disease, the historical 4 disease phases from immune tolerance, immune active, immune control, and then immune escape. And you are supposed to, theoretically, in the clinic, you're supposed to very neatly place a patient into one of those categories, which is absurd, really, because chronic hepatitis B is a dynamic disease. It's always in a state of flux, in a state of change. But I was fortunate enough to work with some like-minded people if you stand and you look at the guidelines, and the very first of those phases referred to as immune-tolerant chronic hepatitis B. The question I had was, well, are these people really immunologically tolerant? Because people have been calling them immune tolerant for 20, 30 years. And by virtue of that, they said, this is a benign disease phase, there's no progression of the disease here, you don't need treatment. And more often than not, these patients are younger patients with very high levels of viremia, and they're carrying the burden of very high levels of virus, having continuously been excluded from treatment. So we wanted to look at this experimentally, and when we did, we were actually able to demonstrate that these individuals are not immunologically tolerant at all. So they were being referred to in a kind of an immunological term, which was supposedly capturing their disease phase, but it wasn't actually true. It didn't represent where they were. And in fact, after doing that, we went and did some more work where we looked at, well, is there actually evidence of disease progression activity? And then we were able to show that these individuals, very similar to their peers who were in the category that could be treated, they had evidence of integration of the virus, evidence of clonal hepatocyte expansion, all of these features, pathophysiologies that were associated with the development of cancer further down the line. So I find myself continuously over the years talking about this disease phase, our work which has shown that, other people have shown very similar things now, so the field has moved on. And there is growing evidence that younger patients with very high levels of virus, and there are many people in the room here I can take a look at who are very similar to me, who go, how on earth could you have 7, 8, 9 log of virus for 10, 20, 30 years and just stand as a physician and say, well, we're not going to treat you because the guideline says you don't meet the criteria for treatment, when we know that there is evidence, emerging evidence and more evidence that these people are actually at risk of cancer. I was on the forum the other night and we're still challenging ourselves as clinicians I was remotely with my unworking slide up, as Mark had a good laugh about. But the point is that there are people who still say to me, but no, these 20-year-olds, they don't have cancer. Or the 25-year-old, they don't have evidence of disease. No, they don't. Because it's a dynamic disease where the process is moving, and they are moving towards the development of cancer. Whereas if you go in and you treat patients very early, you reduce the virus, you reduce transmission of the virus, obviously, as we talked about, but you also take away a lot of, probably most of, maybe all of, those integration events which 10, 20, 30 years down the line lead to a cancer. So from our point, scientifically, I think experimentally, we are quite confident that these guidelines, these disease phases are unhelpful, and then it's our job, my job, Mark's job, everybody's job to really go out and inform certainly the medical community more broadly that we should be considering treating these patients earlier, and by doing so we're probably going to end up preventing what you always hear that statistic, 10 to 25% of patients with chronic hepatitis B will end up with cirrhosis or liver cancer. Unless we start changing the way we look at these patients, treating these patients, that number, those statistics are never going to change. And that's probably enough for me at this point, and I'm happy to discuss some of these points further.
Great, thank you. So I think we've heard from Cami and Michael around the impact that U equals U has had on people living with HIV. Sue, it would be great as someone living with hepatitis B to hear your views on what a U equals U for Hep B could have on people living with hepatitis B.
Sure, and I think, this has been such an amazing discussion, and so much of this has, I think, come out of actually a lot of work and discussion on stigma, and that's kind of wrapped into this. So this has been really an important part of the evolution, and so I think this is really important as we move forward. So I want to share a little bit about my story and also try to share some stories of people that we've heard from around the world, from the Alliance and also Hep B Foundation and ICE-HBV, because I think a lot of times those stories don't necessarily make it to these kind of conferences, even to our exam rooms. I think as physicians, patients don't always tell us what they're really worried about. They come in a very the doctor's here for clinical reasons, and we're going to have my lab results. They're not going to ask you about what's happening with their family and their fears and their hopes and real concerns they have sometimes. So, and even me as somebody living with Hep B, I think a lot of us really just push it to the back. Like, you don't want to deal with it, you feel fine, you push it to the back burner, you rather it not be an issue. So I was diagnosed when I donated blood in college, and I got the infamous, I don't remember if it was red. In my mind, it was like this red envelope. It was like this angry letter. It was, and it said, good news, you don't have HIV, but you have hepatitis B, or something like that. That's how I remembered it. And so I had, called my sister, and I said, oh my God, don't tell Mom, but, I've been diagnosed with Hep B. And she goes, didn't you know Mom had Hep B, or has Hep B? And somehow my sister knew it, but I didn't know. And turns out, actually, my mom doesn't have Hep B, but my grandparents did, and they were both healthcare workers in Taiwan. But so for most of college, I went to my primary care doctor, and they said, I'm a chronic inactive carrier. Oh, nothing's wrong, I'm fine. Obviously this is a while ago, so this is before we knew. Our knowledge has really, really changed. So I think what we said then means something very different if it's said now. And I went to medical school, and I feel very privileged having access to that knowledge. So, during med school, I may have gone to the doctor once, definitely not yearly or quarterly as we kind of tell people to do. But when I met my now husband, I had to think, when am I going to tell him? And even as a medical professional, that's not an easy thing to have that discussion. And you worry somebody's going to freak out on you, reject you, and I was really fortunate he didn't. He was very logical, and had a really good friend who was an infectious disease doctor. And she said, bring him in, I'm going to test him. And it turned out he needed vaccination, and then we were good, right? But you have these points in your life where you're like, oh my God, is the diagnosis going to change and alter my life? I was really lucky now looking back that I didn't have any other incidents during medical school where somebody, and I was very forthright with my I had to show, because we have to show that we're vaccinated or that you have a test result. So I showed them my test result. And I really think somebody just didn't look at my paperwork, because, and we've heard of all other sorts of cases where people are found to have Hep B and it blows up. They have to meet with lawyers, liability, and these expert review panels. So I feel very fortunate. I just kind of Yeah. Because we didn't have the protection that the med students have now. Like now it's protected under ADA. There's been a lot of work with the DOJ. But before that, you know, I could have gotten kicked out. I mean, because that's happened before to med students. So then the next time when it actually kind of reared up again was when we started talking about having kids. And at that point I was working at Charles B. Wong Community Health Center. I actually ran a Hep B moms program. I mean, so I know like everything about what needs to be done. And even then I was worried, right? My viral load's always been, or at that point had been like 1,000 or less. So I knew it was like definitely not at high risk. But I still had to go see a high-risk pregnancy physician, and my OB, when they ordered my test, I had to show them what the test was in the book, because they're like, we're really confused by these tests, just tell us what to check off. And then they counseled me, and when I went in for delivery, I told my husband, your one job is to make sure the baby gets the birth dose at 12 hours. I don't care what else you do. If I'm out of it, you need to make sure the baby gets it. And so they did, and my kids are all Hep B free thanks to the vaccine. So we've got amazing success story with the vaccine, but I worry that the vaccine is, we lean too much on it, and in the real world, so many adults are not vaccinated. So many sexual partners are not vaccinated, and we can't, it has to be a multi-pronged approach. And then I think, you know, I feel very fortunate my life has not been disrupted by this, but we hear plenty of stories around the world where people, you know, find out during pregnancy. A lot of women find out for the first time they're pregnant and then they have Hep B, and they are completely rejected by their spouses. They are accused of cheating on their spouse or being a prostitute. Their in-laws, their own family members will actually kick them out of the house. They'll be asked to get an abortion or sterilization. It's pretty devastating. And other people, the family members will separate them from the family table. They'll have to eat separately. At work sites in China, there used to be a separate table for people who are Hep B infected. I mean, what that does to somebody's psyche, like you cannot underestimate. So people diagnosed early, it often completely changes their career path, their path of like being able to have a family, like Michael was saying. And that stuff doesn't get discussed, I think, in the clinic rooms. So, and we've heard a number of stories of people becoming really depressed, having suicide attempts, definitely, you know, successful suicides in other countries too. So these are outcomes we should be trying to prevent, I think. So, yeah, and then what we also see, so we are part of an online forum called hepbcommunity.org. So I recommend all the physicians tell your patients to go there, because what I tell them is patients have other people the same questions you do. You will find such great support there, things that I can't tell you, because after they leave, then they have all the questions, right? So it's very helpful. And what we hear sometimes is that makes me sad is that people are, and I think Thomas mentioned this yesterday in our section, Thomas too in Australia runs this. People worry, like, if I touch my, you know, if I get cut and my blood ends up on the kitchen counter, what do I need to do? Like, you know, they're obsessively cleaning things. You know, we all know about the razors and the toothbrushes, and I mean, I think that too, and I'm on treatment now, but I think this mess, I was just thinking, because I often, if I like have a cut, I like freak out too, and I'm on treatment, right? So even as a physician, like, unless I have that message, I think as Michael's saying, front and center, you always worry about transmission. And I think that weighs way more heavily on a lot of us than any physical impact that we have from the infection itself. So, and then I think something you had mentioned, Mark, about these healthcare workers or students that end up having these expert review panels, reviewing them, like, it's really intimidating. You have no HIPAA anymore, right? So if you're going through rotation, all of a sudden, the attending who's also, you know, your dean is involved with your medical care. And if we had something like U equals U, like, just make it simple. I go on treatment, I'm done. I don't need it to be like hemming and hawing between the lawyers and the dean. I think that's another barrier we need to try to remove. And Carolyn Wester said, she would review it, because it hasn't been reviewed for like 8 years maybe. So I think there's a lot of room for improvement. So that's it.
Thanks. That was, I think, really incredibly powerful. And this is really why we're here, isn't it, for the people that are living with HEP. So we have one final speaker, and then we'll open up the discussion. So Lewis, you mentioned that you do a lot of work in Ghana, and we know that Africa is disproportionately burdened. So from your perspective, it would be great to hear about what a U equals U campaign could change.
Thanks, and it's really great to be here.
I think often I find myself feeling like I'm the voice of the people that are not at the table, who are impacted in unimaginable ways by a disease that the people who are making the decisions have no idea about. And I think it's really important because in sub-Saharan Africa, I heard someone, we have somewhere around maybe 80 million people with chronic hepatitis B. In Nigeria alone, we have about 20 million people. In Ghana, we have maybe 4 million people with chronic hepatitis B. And in sub-Saharan Africa, the median age of diagnosis of liver cancer is 42 years, 42. And a good proportion, at least a third of the people who are diagnosed with liver cancer in sub-Saharan Africa will not meet any guideline for treatment. That is unimaginable. And I think we as a global community have failed those people. Because, I spoke, I think it was a World Gastroenterology Conference in 1999. And I spoke at that meeting, I was invited to speak at that meeting about global hepatitis and liver cancer. And I said there, we know enough now to make a difference. And all we're missing is the political will. The editor of the Lancet GI and Hepatology approached me afterwards and he said, write a review that's based on the talk you gave. So I read this review and I made the same statement at the end of the review. He sent it to a reviewer who, in their comments, said, this sounds too much like advocacy. So I want you to tone down. I want you to tone down that part of your message. So I did tone it down. But the important thing, just like Mark was saying, everyone I spoke to then said, we really need better data. But just like the problem with grade, these grade recommendations is when people say we need more data, they don't attach any money to that comment.
Exactly.
You see, it's like, I don't know if you heard the story of the pig and the hen. So the hen says to the pig, let's start a business together. And the pig says, what are we going to do? And she says, we'll start a restaurant, and we'll call it Ham and Eggs. Okay. The pig thinks about it for a minute and says, no, I'm not so sure. You'll be contributing, but I'll be fully invested. And that's the trouble, isn't it? We're contributing opinions. These 20 and 22-year-olds with chronic hepatitis B in West Africa are fully invested. And they are the people with it. They are the ones who are facing this risk of, am I going to get liver cancer at a median age of 40? And they feel like they are completely abandoned by the healthcare community because everyone's telling them, oh, you have hepatitis B, your viral load is low, no need for treatment. Even if a third of people with cancer would never meet criteria for treatment, it's like, what? If this were me, I would find it unacceptable. So I was in Ghana just about 3 weeks ago. There's a woman who's on our board, fortunately, of the nonprofit that does a lot of the health education we do there. Fortunately, because she's on our board, she understands, she's heard sort of messages, she's a banker, but she's heard messages about hepatitis B from our discussions. So she has two people that were looking after her mother, who was, has been, ill, chronically ill for the last several years. So these two young women, one of them is 23, the other one is 28. Both, and in part because she knew me, she said, I'm hiring these people, shall I test them for hepatitis B? And I said, well, 10% of the population is hepatitis B positive, you should test them. So she tested them, both of them turned out to be positive. So the first one that was tested had a viral load of, I think, around, at least we got one viral load that was more than 2,000. So I said, well, that justifies it, and she's quite happy to pay for the treatment. So this one's on treatment. And then she said, well, I have this, second worker, she's 28. And so when I was there, she said, can we test her? So I said, yeah, please go ahead and test her and send me the results. And so here she brings the results. Viral load is 142. Okay. So what do you do in this circumstance? And I think that really is the main message I wanted to bring to this group, that you have people that are at risk. You have people who, in many different settings, other than having someone employing them who kind of understands this disease and understands, that the risk of transmission is low and all that, they wouldn't have this job, because the minute they tested positive, the employer would say, no, I can find someone that's not positive, so why take, in quotes, the risk? And as Sue said, we hear this story over and over and over again in sub-Saharan Africa. But I think those are, the perspectives that I thought helpful to bring here. From their perspective, when we make the diagnosis, and if we tell them the truth about the disease in sub-Saharan Africa, they really can't believe that we can look at them straight in the eye and then say, you don't need treatment.
Thank you very much. I can't take notes fast enough. That was really powerful, and I appreciate all of the points that we're bringing up. And we do, one of the things I wanted to talk a little bit about, both with the panelists and open it up to the room, is data. Because we've been talking a lot about it. And one of the questions is, it seems like we may not have enough data for everyone to feel comfortable with a U=U or similar message. Wouldn't it be great if we had a prospective study? Wouldn't it be great if we had the data? So I guess my two-part question. One is, what data do we think we might need? And number two, what data do we think we're going to get? Because, listen, I live this world every day. We can barely get, the CDC's underfunded, NIH is underfunded. No one is funding hepatitis B. I can't imagine that anyone is going to fork over $50 million for a 20-year prospective study on this, even a 10-year prospective study. So my question is, what do we have, what do we need, and where's our middle ground? What would we be comfortable with, and realistically, what data do we think we're going to have to create this kind of messaging? So happy to open it up to the room.
I want to just ask the room, because it's a powerful group of people who has networking connections all over the world. In the HIV world, we get data around hepatitis B. So we have data in people who are on effective HIV regimens that they are extremely unlikely to acquire hepatitis B. It's basically, they're on Hep B prep when they're on their HIV regimen. And what I started wondering was, do we have data where people are being characterized, couples are being characterized for HIV transmission, where we have samples that could be tested for hepatitis B to see if there's any evidence of an impact on hepatitis B transmission? So one thing I wanted to ask the group is, can you think about any studies you're aware of anywhere in the globe that might actually have samples where the challenge is going to be just raise enough money to do some testing on already existing samples, because that's a whole lot easier.
But is there data then on transmission? Like you said, you had data on thousands of sexual exposure. So how does that play in? How do we get that?
You would have to find a couples transmission study, a study where at least some of the, like the 052, it was also asking early versus late treatment and the benefit to the individual living with HIV for earlier treatment. And it had a component of prevention of transmission. It just seems to me that somebody somewhere might have done, another transmission study where we might have serum samples.
So one of the original studies that Tom Quinn, who's at Johns Hopkins, published, this was not with treatment to make undetectable, but looked at the relationship of viral load, of transmission, large study. And I wonder if, you make me think I should talk to Tom when I get back to Baltimore. Because
I guess the question is whether they tested the partners for Hep B also.
Right, you could
right?
do,
Yeah.
you have to do a
Not just
full
HIV.
profile Hep B in both settings. And I'm trying to remember the study, but it's actually, because it doesn't introduce because the issue of tenofovir PrEP kind of complicates it, because that issue. But I think that was a time well before any widespread use of antiretroviral therapy.
That was in the 90s.
It was in the 90s,
Yeah.
There are some pretty big studies, and this may be an extreme example, as I recall, of perinatal transmission using antiviral intervention, whether it was lamivudine or tenofovir, interrupting transmission in the absence where the newborns were not treated with with H-big or vaccine.
And how does the vaccine complicate this? Because even thinking prospectively, we're never going to get the data because we vaccinate or at least we try and vaccinate
The
partners.
problem with partners, I mean, the good thing about partners was people were vaccinated.
Right.
You ensured that people were vaccinated, and so the PrEP studies won't give you that answer because everybody was vaccinated.
Right.
But there's a lot of countries where healthcare workers, if they're lucky, get vaccinated.
Right.
And they've started, vaccinating infants, but those kids are maybe in the adolescence now. There's still a lot of adults that aren't vaccinated.
Okay.
I'm throwing it out there because, we've seen hints of hepatitis B data in the HIV community. It's not. I haven't been able to find anyone who's like, oh, I know this cohort in Vietnam, in China, and it's somewhere. And I've been asking,
Right.
but I thought I'd throw it out there for this group.
Also, want to let everybody know, we have notepads here, because if you have a thought, scratch it down. We're going to collect these in case we don't get a chance to hear from everybody.
Yeah, I just, this is probably a little more primitive on that, but, and I don't know, I'm not certain they've actually done anything with it, but.
Can you introduce yourself?
Oh, I'm sorry, I'm Jeff Baker. I'm with a company called Census Diagnostics, primarily focused in viral hepatitis and HIV, but in my travels in Nigeria and Abuja, talking with the Ministry of Health, Abuja, in Abuja, they have one of the largest sample banks I have ever seen. It's amazing, and I'm sorry to digress, but you'll be sitting there talking with the Minister of Health, and the power will go out 4 times as you're talking with them. And then they take me down to the sample bank that's massive. And I said, how is this? I mean, the power's gone out 4 times and I'm talking. They have a quadruple redundant backup power service for that. I'm not sure how they're cataloged or not, but the sample bank is massive. And considering the size of the especially Hep B positives and the HIV positives in Nigeria, it would seem like there would be enough of a sample size to address this, but
if we went back to Sherry, I thought Sherry asked a very good question, like what would the group be comfortable with? How much data is there out there now? As we were saying, I like the way Homey put it, and saying logic. I mean, pardon?
Like from a public health perspective.
Well, I don't know. I mean, I've never been really comfortable separating the logic from evidence. But I like the way you put it, so I thought that was very succinct. I mean, I'd like it to be evidence-based, but I do agree with that, as Mark said, you don't want to make it unattainable. It has to be reasonable. And is that information there now? I assume it is.
I was thinking, as I was hearing people talk, I was thinking, of
But I'm Tim.
you can actually write a section that lays what we've talked about today out.
Yeah.
Because I think, so you made a point about vaccine. It is, vaccine is not by any way completely uniform. No. And so when you sort of say that this doesn't matter because we have vaccine, you're ignoring all the data to suggest that's simply not true. But we could say that. You could actually lay out a pretty logical area with the idea of empowering this conversation to happen with individuals, and then actually lay out the data that's needed. But I raised the example of 2012 because it said we need long-term studies,
right,
and nothing happened, to your point.
Right.
Well, I think an important point to bring up is we don't have 20 years.
Another great point.
So vaccination started in 2001 in sub-Saharan Africa. I do modeling. My name is Devin Razavi-Shear, Centers for Disease Analysis Foundation. Lots of complex modeling. A lot of times you can just do it on a piece of paper. Vaccination started early 2000s in sub-Saharan Africa, and median age is 42, which means the bolus will be over by 20 years. So we're just going to let all these people die before we get the data. And also the data isn't 100%. If we truly believed that everything needed to follow data, then there would have been an immediate emergency meeting of AASLD and EASL when the Cochrane review came out saying that Hep C treatments have no evidence of preventing cancer. We all would have come together and said, we need to do this because the evidence, look, it's a Cochrane review. Robust evidence the treatment does nothing. Instead, the entire field said, oh, that's just trash. That is garbage. So whereas Patrick has shown, and Mark has shown, that we have lots of people who are developing cancer who are not under the guidelines, and yet nothing's being done. And I think there isn't it might not be the great evidence, but why is it that we ignore really high quality evidence when it goes against what the people on the guideline boards think, but they ignore the evidence that goes against what they say, so.
I think there's another comment. It actually relates to hepatitis C and the risk of transmission between spouses. Because that risk, if I remember right, is not zero. But I remember counseling many patients who asked the question. And I said, you know, there is a small risk that has been documented. It's been carefully discussed in the scientific community. And the CDC does not recommend that people do anything special if they're in a monogamous relationship. So the CDC was able to take a situation in which they actually had evidence that there's some risk of transmission and say it is not significant from a public health perspective, and it's not worth placing the burden on patients, you know, of worrying about this. It's really interesting that we were able to do that, but in the hepatitis B circumstances, we refused to.
Liz, don't you think it's a little different if you transmit something that's curable compared to if you transmit something that's not curable? I mean, I think that, we all bicker about all kinds of things that came out of with Hep C because evolution of therapy has really changed messaging quite a bit. And I think that, you would never take a 20-year-old with Hep C and choose not to treat them. But where is your cut point in treating a mother to childhood transmission? Do you start treatment at 3? Do you start treatment at 7? When are you integrating DNA the entire time? So I think that some of the struggle with Hep B therapy isn't so much that we don't think treatment would impact cancer rates, that we don't think treatment would impact disease progression. It's that there is not an obvious time to treat. And don't even get me started on screening. We don't even know our Hep B patients, right? There is no universal screening. You should probably be screened for Hep B every decade, right? That would make sense. That would capture high risk factors. It would capture maternal to childhood transmission, marry it to lead testing for children. Take something so you are finding Hep B. Because I find Hep B when I have a patient come in with a 12 centimeter cancer, not because I had Hep B that I chose not to treat. So there's a lot of layers in there. There's the ideal world, but then there's the fact that we don't know where Hep B is. We don't have an obvious time point to say, well, you're 17, we'll start treating next year. When do we initiate therapy in these individuals? And treatment decreases viral load, but it's not like U equals U, right? If I treat an immune tolerant individual with Hep B, I may not get full suppression, and even though we don't think TDF has viral resistance, we may still not. That's where you want the data, right? You want to know that you're doing something that's the right answer. And I'm not saying it's the wrong answer, but I think that those are the gaps that we struggle with when you're writing a guidance or a guideline or just a public health message.
So if a 7-year-old came in with syphilis, when would you decide to put him on treatment?
Right away, right?
That's exactly right.
But do you think you can get the pediatric community to say that children that have maternal to childhood transmission should be started instantaneously on Hep B? If it was my child, I would. But my pediatrician may not agree with that.
So Ahmed Al-Shakawi from Birmingham. I totally agree, Nancy, but equally I flip it around and say, I agree conceptually with your argument, Helmi, but the issue is that many of our colleagues out there, we can't even get them to agree to treat a viral level between 2,000 and 20,000 because they are so rigidly sticking to guidelines. You need to show them the data. But it strikes me that we don't even know. I've not seen it anywhere. Someone synthesized the data on transmissibility and for Hep B. I've not seen it. So one of the arguments, Nancy, may be that actually, if you are a parent of that child and you have got other children, do you want your child to be running around with a viral load in the billions? Because you don't know what kids get up to. And it could actually be that one child transmits to others. Yeah, so actually, we just simply don't know all that information. We don't know enough about the history of transmissibility. So yeah, we talk about maternal to child transmission, but actually, is there a household transmission happening amongst siblings, amongst cousins? And there's some evidence, I think, from the Amazon in terms of Delta, from that point of view. So I think there's so many data gaps that we don't know.
But there is data. That's the problem. I think we just haven't synthesized it. So there was a study among Belgian missionaries working in Africa, and if they adopted a child with hepatitis B, the other household children were much more likely to be infected. Exactly. There's actually a lot of data, and there's data from Amazon as well. Hepatitis B, after measles, is one of the most infectious viruses in the world. After measles. That data is pretty well established. In fact, it's on CDC slides. I'm not sure why we have these discussions. There's ample evidence.
Because no one synthesized it and put it out in a digestible form. And that's why we need to get the patients on board saying, we don't want to be transmitting these infections.
There's another side of it. I'm sorry, let me just continue. There's another side. So Patrick and I in a group have actually written just a paper based on the available evidence.
Okay, good.
We can't get it published. None of the hepatology journals have accepted. Devin has written a paper on cost effectiveness and test and treat all in the US. Every hepatology journal rejected it. We're now going to infectious disease journals. This is a huge problem, which is if you go against the guidelines and you're trying to put something out there, reviewers reject it. So is there data out there? Absolutely. Can you get it published in peer review? God help you trying to get it out there. Not in hepatology journals. It'll have to go to infectious.
What about WGO? I mean, I know it's not a high impact, but it does have readership. I mean, I think that sometimes these alternative societies that are looking for data that have touch points across the globe you won't, it's not Annals, it's not Nature, but it's still going to be read.
So I'll make another point about this, is that one of the things that happened with hepatitis, so I'm an ID trained doctor, and in 1996, 97, I started to do hepatitis C, and I was definitely an outlier. It was an ALT disease, it was a liver disease. In fact, I was told many times, stay in your lane, this is a liver disease. And when we think about Hep B, the reality of it is we are thinking about it like a liver disease in many of our publications, in many of our professional societies at this meeting. And what we're talking about, transmission, that's infectious diseases, classic infectious diseases, and it's a mindset change. So it does, and one of the big breakthroughs in Hep C was to have the ID Society, at least in the US, work with the AASLD. So it's interesting, it's got great discussion, lots to think about. In fact, I just sent email out to try to follow up with some stuff.
Thanks very much. Hello everyone, Mark Sundrup, I'm from Cape Town, South Africa. It's seldom you come to a meeting that it sounds like you're listening to Beethoven's Ninth Symphony because it's that beautiful. Because I think we're finally actually getting to talk about what we actually need to talk about. I'm going to make a couple of points because I came a bit late, and if I'm saying things that have been said, I apologize. I was at the cold AASLD session. To fix this problem, we need to deal with our own house first while we're dealing with the community. All right. The problem in our house is we teach hepatitis B at undergraduate level completely incorrectly because doctors and other healthcare workers come out of university or college thinking hepatitis B is a graph. There goes the surface antigen, there goes the surface antibody, there goes the viral load, there goes the E antigen. That is their understanding of hepatitis B. That is us. There's no one else to blame, it's us. Number one. Number two, for every infectious disease or disease, we talk about natural history, and it's so critically important to understand natural history. What we've done with hepatitis B is we haven't de-linked natural history into common sense. We did that with HIV. We don't talk about HIV not understanding that this is an OI, stage 3, stage 4. We still use those terms. But HIV, we all understand is a viral load, CD4 count, treat, etc. but we still have a good understanding of natural history. What we've done with hepatitis B is we've never delinked it. That's why we still talk about immune tolerant. And I'm against doing away with the terms because it makes people understand the natural history. Once you understand something, you can damn well treat it properly. If your understanding is a graph going in all directions, you're not going to be able to understand why you're treating somebody. So we need to get the terminology sorted out. We, maybe I'm not that old, but we are still labeling people, I'm just a carrier. No, you're not. You have a chronic infection. You actually need care. It may not be high-level care, but you need something. Can we get our own house sorted out and get the damn terminology sorted out and move on so that people can actually just demystify this infection? Why is it so mystical? I don't know what your experience is. It's still a mystical issue to doctors. And so you were talking about your serology that you were laying out. People didn't know what they were looking at. I bet you there were doctors looking at that serology that didn't know what they were looking at. But that's us, Sue. Anyway, I want to make one last comment, otherwise I'll be on my pedestal here the whole day. But the point is, we need to get our own house sorted out. The data issue, I want to agree with you. I'm so sick and bloody tired of hearing about where's the data. The data is there. It may not be Cochrane level stuff, but it's there. And I want to encourage you, don't chase the impact factor, get it out. It's a good point. Put it in the WGO. Let's talk about this, all right? Let's get this debate going. Otherwise, we're never going to move forward, right? And finally, about teaching things. We're talking about prep kind of thing, and that's all great. That's all great. But the point is, let's just be honest. For the vast majority of this planet, where hepatitis B is endemic, infection doesn't dominate in adults. It's child to child or perinatal, right? That is about vaccination and prevention. It may not be complete, Mark, I agree with you. But that is the dominance. I mean, we have doctors in sub-Saharan Africa still on meetings, Lewis, you know it, when they present a patient with hepatitis B at 29, they'll say, monogamous relationship, doesn't sleep around. I mean, the patient acquired hepatitis B when they were 1 year old, okay? It's got nothing to do with it. That stigmatizing, but that's us, it's the way we teach it, Lewis. That's the problem, all right? So I want to say we need to get our own house in order. A lot of work to do, but can we just get our own house in order first of all? Thank you.
Thank you very much, Roy. So we have about 10 minutes left. I want Jackie, then Patrick, and then I want to start talking about next steps.
Hi, my name is Jackie. I just heard about the child infection, and I want to share with everyone one experience that I'm having now. So I've been running an international sort of support group, so online. So basically, mainly focusing people in Taiwan and also around Asia country that they speak not English, but mainly in Chinese, Mandarin, and other languages as well, since we can speak multiple languages in the group. Now, I want to share with you one experience in the past year, is that there was a mother, she was in her 30, 40, and she was basically crying, asking for help, because her 3-year-old was found to have chronic Hep B infection. And she would do everything, anything. She said, I will do anything you can help me to get rid of the virus from this young children, only 2-3 years old. She feels so guilty that she, transmit the virus to her. However, she did everything. I said, you did everything you can. The kid was, when she was born, she was like vaccinated, HBIV, everything they can do. But still, there were a chance at that time that because mother was not antiviral, right? So the kid gets infected. So what can I do? I cannot just say, here's a drug, take the drug, and then I cannot do that. So what I can do is that, all right, I'll refer you to the best doctor, the pediatric HBV. She has spent all her life studying pediatric HBV infection in National Taiwan University. Mei Hui Chang, I think some of you probably know her. So we send her there, we get in contact with the doctor, and the doctor, there's a group of team there helping the child. So they eventually, so they sort of travel, a long distance to see the doctor. Now, we know at that time we contacted the doctor saying, what can you do what can you help with this kid? And his ALT is elevated as well, slightly, but elevated, in the 50 to 100, in that level. However, so the good thing is that they are running clinical trial, right? The TAF in young child, they are running that clinical trial. They are doing that. However, there's a criteria is that he will never meet that criteria. And there's also a guideline that they can treat if the elevated ALT is about 2 times normal level. But she will never reach that level. So unfortunately, at this moment, we cannot do anything for the kid, and all we can do is just try to support the family, saying that, you have to keep monitoring. And we, for the support group, that we will just have to follow that family, probably for the next 10, 20, or even a lifelong time. However, there's a good thing is that when we found out that, then I say, this is important. You and everyone in your family have to get tested. So the mother is happy, positive, obviously. Not only that, her ALT is elevated. We were so happy that she can get on antiviral treatment right away. So that's one thing that we can do with that family, with that mother. So make sure that she's taking care, then she can take care of her child. And then we will have to find a way to see how are we going to deal with a young kid who has slightly elevated ALT, very, very high viral load. We have to continue to do those studies to see when we can treat that patient and have the kid have the best outcome in the next 10 or 20 decades. So that I just want to share that story. We are following the kids, the family, and see what we can do to help them.
Yeah, that's a good point, because if the guidelines are more flexible, then the national health insurance would cover treatment, so.
It's a subtle shift too.
Yeah.
It's giving permission to have that conversation.
Exactly.
It's a subtle shift, but it actually is very powerful.
Thank you.
But determining when you're going to do that, when you're going to start treating these kids. I'm a parent of a kid with Hep B, and she was treated starting at 14 months at Hopkins with Dr. Schwartz. Yeah. So it was it's interesting listening to Dr. Rhodes say, when do we start treatment? I mean, she did start. She's actually cleared the virus, but I work with a lot of parents, and their kids are I've seen kids that are adopted kids that are treated completely differently, where the mom's running around with a little pack, and every time the kid touches something, this is in their own family, right? Because they're worried about transmission. So it's heartbreaking. That's in the United States. Other countries, it's just horrific what goes on with these kids and these parents. So coming into here, I would have said, I don't know about treating, early on like that, but listening here, I wonder, maybe we really should be starting it. I even worry about my own kid that cleared it at 4. What about her? I keep telling Tim, she has an antibody level of over 1,000. Why? If she cleared the virus at the age of 4 and she's 25 now. So something's still going on in there.
Thanks, Marie.
But, the very few studies of treatment of pediatric chronic hepatitis B is unbelievably successful, actually. And that probably fits with a lot of what we think, that the earlier you treat patients, the earlier you go in, the better you do. Chronic hepatitis B, over a lifetime, just destroys your immune response against the virus. That's why you don't get rid of chronic hepatitis B in your 4th, 5th, or 6th decade. But I want to come back to Michael's point, because he makes a very good point about getting our own house in order. One of the issues that I kind of rail against, Michael, is, immune tolerant, because you've got, or immune inactive, etc. You've got physicians who see those labels and they go, immune tolerant, no treatment. Inactive, yes. No treatment. And that's a massive problem. So we have to break those linkages where people just associate one thing with something else, and that's the reason why they don't offer or consider giving people treatment. I'll finish with one final point. I was on the NICE guidelines, the UK guidelines for chronic hepatitis B, and it was a very esteemed group of people sat there. It took the lay member of the community to go, why is it that you wait until there's liver damage before you treat chronic hepatitis B? And they're all going, yeah, that's actually very good. But 10 years later, it's the same thing. So we have to change these guidelines, and that starts with us, and that starts treating more patients, and that starts with the companies pushing trials into those special groups of patients who currently aren't offered treatment.
So Patrick, if the pediatric data is good, but the immune tolerant adult data is bad. When do you lose that?
It's a very good point, Nancy, but those very few studies from King's and other places of treating children, 3, 4, 5, they do well. They do well.
Yeah. I mean, I had a couple of adopted children who had Hep B that I treated in their late teens because they needed to go to college, and I had to sign a letter saying that they wouldn't infect the people in college. So I just treated them and wrote the letter. And they both cleared, surface antibody positive. And I was kind of mystified because, the dogma, putting your own house in order is always treating these immune tolerant people. It causes less viral suppression, and we didn't have TAF back then. I treated them with something that had, potential for resistance, and so I really worried. And they were siblings, not siblings; they were adopted siblings. So, but I think that if that's that's a message that's really important because I would have said I should know this data, and obviously I didn't.
Probably your immune exhaustion is happening around the time when you antigen seroconvert, naturally, so it probably is late teens, early 20s. But actually that's probably when your immune system is primed to actually clear. And you just give it an extra push with your nukes, probably.
Right.
But we don't know.
But that would be really important to know because you would be switching your lifelong therapy to lifelong therapy in a lot less individuals.
Absolutely.
I mean, maybe it's lifelong therapy, but the opportunity to seroconvert is now no longer like 4% or something.
Isn't that a really easy clinical trial to design?
Was it there's your clinical trial?
Well, the majority of these kids aren't here, right? They're not in countries like the U.S. or the EU, so they're all around the globe, and it's very hard. They contact me, what should I do? You're almost reluctant to tell them to go to see anyone because, most of them can't afford it. They won't get a doctor that will treat them. So it's really, you can't find a pediatric specialist there, and they don't know what to do with them, basically. They really don't know what to do with them.
So going back to what Mark and Mark were saying, what can we do, like in terms of, like recently there was a consensus meeting about NAFLD, right? Can we do something like that for Hep B? And ILC, I had the same conversation with somebody on the governing board about, just the terminology, right? It hasn't adapted to, based on what we know. So is that a start to work on that before we go for, or I guess we kind of need to do it with the guidelines. AASLD is starting to gather their writing group for the Hep B update, and WHO will be also meeting later this year, and I think they're hoping on convening. So really timely, but I think we got to push or we're going to end up with guidelines that look the same.
I think that's a really important point, is to make the point that hepatitis B is not the same around the globe. One of our problems in Africa is that our guidelines are based mostly on data from Asia, and really, I think, are leading to what some of us consider to be malpractice in Africa. And of course, when they tell us we have to do the clinical trial, and as we've said, nobody, along with that advice, gives you a ton of money. And so, but it takes me back to Mike Ryan, reminding people of what he says about viruses and epidemics. There's no perfect data. You're going to have to make the decision about what you do based on the evidence you have at the time. He says you have to act fast. If you don't act, the virus will get you every time. When we have Zika and we have Ebola, much less, eventual public health impact. But that's because as soon as we recognized those as problems, we did something. We had not perfect evidence, but we acted. Hepatitis B virus is killing 2,200 people a day. 1.5 people, I think, a minute. If that doesn't qualify for an infectious disease that needs attention, I don't know what does.
Lucy, you have too much evidence now.
Lucy, I just give you a very quick follow-up. Can we just also agree that as we stand here now, the best metric for assessing disease remains HBV DNA? That's the best metric. Okay, let's just be clear on that. And that metric should apply across the board. So when WHO are rewriting this year, That is the metric that matters. I know Mr. Baker's sitting right here. He needs to hear me because that is the problem. Lewis, those patients you're talking about from Ghana, how much did they have to pay for those HBV DNAs? You know, that's the problem. The problem is the metric we're using that is unavailable to the most.
Great, thank you all. So we're past 9 o'clock. This has been an incredible discussion. I think really like one of the key messages that came out is that the current guidelines are a huge barrier. We know that different organizations are looking at guidelines. Some of you in the room might be on those committees. We really need you to make these changes because, as Lewis pointed out, it's the people living with hepatitis B that are fully invested. So the Alliance, the Hep B Foundation, ICE-HBV are really committed to continuing this conversation. I think we see this really as just the first step in what will be a number of conversations in making sure that we get to a point where we have a similar U equals U campaign for hepatitis B, and people living with hepatitis B have that same hope and that same, transformational impact that people living with HIV have experienced. Shari, I don't know if you want to.
That's it. We're gonna keep working until we get there.
So thank you to all our panelists and thank you to everyone for coming.
You've all just committed to